very good evening to everyone. Today, on behalf of Andhra Pradesh Audiologists and Speech Language Pathologists Association, State Branch of Indian Speech Language and Hearing Association, I am privileged to welcome our esteemed speaker and advisory member of Apaslpa-Isha, Dr. Vijaya Narne sir, whose profound contribution have significantly impacted our association over the years. His unwavering support and guidance have been instrumental in advancing his expertise and dedication are invaluable assets to APSLPA. And we are truly grateful for your presence this evening, sir. Also, I would like to extend warm welcome to all the participants who are attending and joining this evening on this special occasion. Yes, this is our day. I wish a wonderful audiologist day. Today, we honor all the audiologists, architects of auditory transformation, who restores not just hearing but human connection itself. As Helen Keller said, blindness separates people from things. Deafness separates people from people. Audiologists break that divide, ensuring the symphony of living reaches every ear, blending science, compassion, and technology to unlock the power of sound. Let's celebrate us, audiologists, unwavering dedication to advancing auditory health and transforming lives, making science a pause in the melody of human experience. With this note, once again, I wish all the audiologists a happy Audiologist Day who work tirelessly to provide the best services and to provide the quality of life to all the patients. Without any further delay, we will move on to today's topic, which focuses on recent updates on clinical aspects of tinnitus management. Before we begin, today I would like to give a brief introduction of our esteemed speaker, Dr. Vijaya Narne sir, a renowned expert in the field of audiology. So before that, sir have completed his post-graduation studies in the Mysore University and his Ph.D. studies at All India Institute of Speech and Hearing, Mysore, Karnataka. He started his lecture in audiology at Svikar Academy of Rehabilitation Sciences in the year 2008 as well as in Aish in 2010. In between, he continued as research audiologist in the Department of Linguistics, Sydney, Australia in the year 2009. Later, he has continued as associate professor in audiology at Gulf Medical University, UAE in the year 2016. He was reader in audiology in 2017 and further in 2018 have done his postdoc fellow at South Denmark University. He later started his career as senior project scientist in the Department of Mechanical Engineering, Indian Institute of Technology, Kanpur. He has 7 years of teaching experience for both UG and PG students in audiology, more than 15 years of clinical research and administrative experience. He has received awards and achievements in institutional prize for developing Excel VBA-based software for client register along with databases and computerized software for disability certificate by the head of the institute. Best paper award at international conference. Also developed novel screening protocols and novel speech enhancement technique. He has published more than 40 papers in national and international journals. In his publications also in a very reputed journals. That was a wonderful journey of yours, sir. Thank you for your patience. We are now waiting for your presentation. Now I'll stop my share screen. Sir, am I audible?
Yeah, you're audible.
Yes. Yes.
Can I share my screen now? 1 minute.
Yes, sir.
Yeah, I'm in the middle of so many things, so let me close all of them. Okay.
Yes, it's visible, sir.
Okay.
Yes.
Whom is requesting to bypass the system private? Okay. So it's visible now?
Yes, sir, it is visible.
Yeah.
Yes, sir.
Am I audible?
Yes, sir, you're audible.
Yeah. So I actually spoke to some of my friends and they told me that I need to talk about this topic. Okay, it's recent updates on clinical aspects of tinnitus. I just made up my own title. Okay, so this and some critical views. So before I actually go on to talking about tinnitus and assessment and rehabilitation, uh, I want your inputs. What are the clinical difficulties that you are facing, and anything that you know about tinnitus, and any difficulties that you are facing in the clinics related to the patients. So, if you please tell me, then I can slightly modulate my presentation.
Sir, do you want me to read the questions what they have posted, sir?
Yeah, no, I'm reading it. It's okay.
Okay, sir. Oh, okay, sir.
Okay, any more questions? Okay, so can I start?
Yes, sir.
Yes,
Yeah.
sir.
So I've gone through the questions. So I think my presentation will answer most of them. Maybe one or two I can answer later. Okay, so I think all of you know what is tinnitus. Tinnitus is actually derived from a word tiniri, meaning to ring. Okay, it is basically in the absence of sound, we perceive a sound in the ear that can be pure tone or it can be a noise, any kind of them. Largely, tinnitus has been classified as two. So we only handle subjective tinnitus, but objective tinnitus is also there, where the other person can hear the tinnitus of other person. Okay, that's very rare. It's like you may see one patient in 1 lakh, so we may not get such patients. Okay, so and I have not seen anyone having a objective tinnitus. So tinnitus affects large number of population, and it basically gives some psychological problems. The person develops psychological problem because of the tinnitus. So origin of the tinnitus is not clearly known by anyone. Okay, so there are some theories which they say it is because there is a disturbance in the cochlea. So that disturbance makes a neuroplastic changes in the higher level, and that leads to tinnitus. But none of the theories are truly correct, and we really don't know from why the tinnitus is coming all along. Okay, but tinnitus can be of buzzing sound, ringing, humming, or whistling kind of sound. So, clinical assessment, as usual, what we do in audiology. So, you have to do the clinical assessment for tinnitus, and like you do take a case history and do the Putin audiometry and all that. But there are so these are what is recommended if you find objective tinnitus, and if you find a subjective tinnitus. This is the recommended protocol. So I'm just sharing with you, and there are some red flags, which means if you find any of these in a patient, then it is better send them to a medical consultation, and you don't handle such patients with tinnitus immediately. You wait till you get a medical confirmation that they don't have any severe other medical issues. Okay, so these are just red flags. Okay, now coming on to the true tinnitus assessment. Now, see, all along, whatever I told you, it's I think most of you know it. Now, the problem with the tinnitus actually started something like this. Tinnitus was not very popular when probably if there is somebody who studied in the year of 2000 to 2008, they wouldn't have heard tinnitus as a major issue, and rehabilitating for tinnitus is very important, was never a concern at that time. Okay, so I think probably from the year 2005 onwards, only the tinnitus became too much into the clinics, and many people have started talking very late. That's somewhere around 2010 to 2011 is what it became very popular in the clinics, and people started talking about tinnitus. Okay, now why was tinnitus became very important? Why not was tinnitus not there before? So whenever we see any clinical condition suddenly becoming too important in the clinics, okay, we should have two questions in general. I'm not just talking about tinnitus, any clinical condition. If it is becoming too popular, we should have two questions in general. One is, why is this important now? Was there any changes that has happened? Or is it that probably we don't have any tools previously and the tools are developed now? So out of these two questions, most often it goes like this. So there are some developments that happen. So they wanted to incorporate them and then test them and see what happens. Okay, so I'll tell you a small story that happened some time back, probably when I was doing my master's degree. So with that, I have actually learned a lot of things. Okay, am I audible?
Yes, sir.
Yeah. Okay, so the story goes like this. I was joined my master's degree, and that is the time auditory steady state response was very popular in the clinics, and many people are talking about it. Okay, so our where I studied, that institute has bought some four equipments for testing auditory, for measuring auditory steady state responses. So I did my first dissertation on auditory steady state responses. So probably I was the first one in that institute to record auditory steady state responses on normals and hearing impaired subjects. So my supervisor told me that your dissertation will give norms for the people who take up such studies later. Okay. So I was very encouraged. So I did my whole dissertation. So all along, my question was only this: is auditory steady state response reliable? Okay. So I finished my dissertation, submitted, and after 2 years, I think there were some articles came up saying that in auditory steady state response has too many artifacts and it's not reliable and all that. Okay. Now, then I actually felt very bad. 1 year I wasted my whole 1 year just to understand what is this, and now people are saying it's just waste of time. And then, but that question was still in my mind. I went to my postdoc in Australia. I met a person called Gary Rance. He's one of the team member who developed the equipment for auditory steady state responses. So I went and asked this question. See, when you are very sure that this equipment does not give a reliable responses, why did you release it to the public, or why did you release it to the market? So this is my question to him. Okay, so he told me, he gave an answer. He said, see Vijay, when we do something, it's not always that, we keep public in mind. We have some funders, we have to obey them. Whatever the people who are funding us, we need to listen to them. Okay. So this is the story. So what he told me was auditory steady state responses was actually brought by the cochlear implant company to increase their sales. It is not to improve the clinics and diagnostic aspects. It is just to improve their sales. They actually brought this auditory steady state responses. Okay. But anyways, that did not stand up in the clinics, and that anyway went away. So now, so whenever a new disorder or whenever something new comes up into the clinics, most often we jump onto it and start using it. My perspective is, because I had this experience, so I always tell the people, wait and observe, and then you start doing it. If you suddenly jump onto it, we may end up making some mistakes. Okay. Now, I will relate this to the tinnitus slowly, but so remember that whenever something comes up in the clinics, it is not to improve the client life, it is also to improve somebody's finances. Okay. So always keep that in mind. Patient description of tinnitus and its presentation. So the tinnitus can be unilateral, and tinnitus can be bilateral. If the tinnitus is unilateral, it can indicate there can be a tumor or any serious medical conditions. If the tinnitus is pulsating, it is usually cardiovascular, so that has to be taken care. And patient description of provoking or elevating factors, and patient description of functional impact on quality of life. So before you actually take his history, please talk to him in all these aspects, and you get the patient have his audiological examination done, and then do a complete audiological evaluation, and if possible also do a balance testing. Okay. So, and then we have to do this something called tinnitus loudness matching. So ideally you should start with the tinnitus loudness matching and then go with the tinnitus pitch matching. I think all of you know how do you do this, but I'll tell you, you ask the patient whether the tinnitus is of noise type or a tonal type. If it is a tonal type, ask him slight description of it. So if you think it is high frequency, then use some high frequency and try adjust the intensity and find out at what intensity he is able to perceive the tinnitus. Okay, now once you know the tinnitus level or the level of tinnitus, that's basically the loudness matching. And whenever we do this, please repeat this at least some 4-5 times. Okay, so that we are sure that the subject is reliable in his responses. Now, but usually the problem is like this. You may not have exact frequency that matches with subject's tinnitus, but it's okay because you have your audiometers mostly allow only 1 octave shift and maybe 5 dB step size. So you may not get exactly, but that's kind of okay. Now, I always suggest do this first before you do anything. Get your tinnitus loudness matching, tinnitus pitch matching, and I'll tell you why later. Okay, and then do the pitch matching. I am presuming that all of you know how do you do pitch matching and loudness matching, so I'm not going into the details of it. So pitch matching, to compare the pitch of the tinnitus, the patient will be presented with external tones of various frequencies. So this can be a tones or it can be a narrowband noise. And then ask the patient to match it. Now, it is usually difficult for a patient with a tinnitus. Now, if the patient has a unilateral tinnitus, then you can present it to the other ear and try to match the tinnitus in the other ear. If the tinnitus is on the same ear, and if the subject finds it difficult, that he is not able to match it, okay, then what you can tell the patient is, you change the frequency and you change the intensity till tinnitus gets obscured by your stimulus. If the patient says that he is only hearing your stimulus and not the tinnitus, then you are able to match the tinnitus pitch and intensity. Okay, so this is a tip that you can take up. Now, and once you have this tinnitus loudness matching, pitch matching, it is important that you administer some questionnaire to know the functional difficulties that tinnitus is causing in this patient. It can be functional index, it can be tinnitus handicapped inventory. I think tinnitus handicapped inventory is more popular than other ones, but whichever is available to you, whichever is convenient, you can administer them. Okay. In case if you don't have them with you, and don't worry, basically you should ask the patient what type of difficulties that he is facing with the tinnitus with reference to his life. Okay. Is he able to sleep well? Does he have any other problems? Is he able to concentrate while working? Is he able to give time for his family members? So these type of questions only will be there in all of this. Okay, don't worry. So you basically ask him what type of problems that they face, and whatever the answers they give you, please write it down and keep it. I'll tell you why to keep them, but have them with you. And now I go on to the tinnitus management, which is the most important one. Okay, so before I go on to the tinnitus management, there are many types of tinnitus managements are available, and some are being I say marketed well than others. Okay, so the ones which are marketed well, I'll name them. One is CBT, cognitive behavioral therapy, and tinnitus retraining therapy, and tinnitus maskers. Okay, these are the three groups which have been marketed very well in the tinnitus, but I'll tell you the ground reality of all of them. Okay. So in general, there is no cure for tinnitus. Please do remember, if somebody gets a tinnitus, okay, now I'll actually give you the physiological evidence of why the tinnitus comes in. Oh, okay. So I'll just tell you why the tinnitus actually comes in. Okay. There are two possible reasons. As of now, we don't have a clear evidence for any of them. One, if a patient has a hearing loss, there is more likely chances that they will have a tinnitus. Usually, the tinnitus comes for high frequency sloping loss patients who are kind of hearing loss is because of either NIHL or presbycusis and Meniere's disease. In these three type of patients, we usually see tinnitus. And if the patient has a mandibular any joint issues at the mandibule, also they get a tinnitus, but that is can only be cured by ENT doctor. So we have nothing to do with it. Other than that, usually tinnitus is seen in most of the presbycusis patients, Meniere's disease patients, maybe some patients with ototoxicity, you see a tinnitus. Okay. Now, if the tinnitus comes only if there is a pre-existing hearing loss, because there are structural changes in the cochlea. So whenever there is a structural change that happens in the cochlea, the structural change will induce a neural changes at the cortical level, which in turn starts sounding as a tinnitus for you, and where this is taken up by the limbic system. If you give a negative reaction to something, the limbic system pops up his activity. Okay, then the limbic system takes it and then it processes the negative thoughts more, and you end up in the negative thoughts because of tinnitus. Okay, so this is what the whole story of tinnitus if there is a cochlear loss. Now, tinnitus can also come without cochlear hearing loss and no other medical conditions. So this comes only, there is no clear evidence, there is no published studies, but I have seen around some 50 patients when I was working in JSS, and I also hear somebody talking about it. So that comes because of lifestyle changes. Okay, so somebody who had a regular lifestyle, who wakes up in the morning, works till evening and sleeps in the night, okay, and suddenly because of his job or any other issues in his life, he has to wake up in the night and sleep in the daytime. Okay, so because of that, you can't get a good sleep in the daytime. So there is sleep disturbances, which in turn affects the whole body. So which in turn generates a tinnitus. Okay, so tinnitus is also can also come without hearing loss. Tinnitus can come with hearing loss. Most often, tinnitus which comes with a hearing loss can be cured with a tinnitus masking or any of them. They usually have residual inhibition and they work. If a tinnitus comes without hearing loss, it is more of a psychological issue and that has to be handled in a psychological way. I am not very sure if the tinnitus masker will help them. Okay. So keep this in mind before we start talking about the management. So in general, there is no cure for tinnitus. Some individuals with tinnitus do not find it bothersome, so they don't take it tinnitus as serious issue. So for those patients, you don't have to worry about any treatment. Just tell them that if they are slightly worried, just tell them that tinnitus does not make your hearing bad or it's not a serious condition for them. Okay, just give a supporting words so they will be happy. If it is not bothersome to them, okay. For others, it can be deliberating, causing emotional distress, negatively impacting their life. For these people, they need a rehabilitation. Tinnitus management may include one or more of the following. Now, how do we know the subject is having a bothersome tinnitus, not bothersome tinnitus? I told you that is why you should administer the questionnaire. If you're not able to administer the questionnaire, talk to the patient. They will tell you whether it is affecting their life or not. Okay. Now, most of the tinnitus rehabilitations are about giving information to the patient about tinnitus and educate them. Now you may ask what to educate them. What is there to educate in tinnitus? It is like this. Okay, you know about tinnitus and you know that it is not life-threatening or causing any difficulties until or unless you have ruled out the red flags that I have given previously. Please do remember that. Okay. Now, once you confirm that they don't have any red flags and it's just a tinnitus, then you have to make sure that it is not a life-threatening condition for them, nor the tinnitus decreases their hearing. That you have to assure them. And practitioners may provide information related to a specific cases of tinnitus and potential management strategies. So, now, does the hearing aids help tinnitus? Yes, indeed, hearing aids help tinnitus, but not for all of them. So, as I told you before, if the tinnitus is because of hearing loss, and if you're going for a hearing aid, and if you can provide a good amplification which is adjusted by talking to the patient, then most often tinnitus goes away. There are many reports which show that tinnitus goes away, and there are some hearing aid companies which introduce notch filter for tinnitus, or they add extra noise to tinnitus to remove the tinnitus. There is no advantage being reported by any studies by and large other than the hearing aid company studies. I don't see any published reports saying that really helps. I think we had a project when I was in ICE. We did it and we found that at least 60% of the patients who had a tinnitus with a hearing loss, when you fit them with amplification and fine tune the amplification as per the client requirements, tinnitus is not affecting their life after that. Okay. So this was my experience with the tinnitus fitting hearing aids. Okay. So the same applies to the cochlear implants. Most of them, tinnitus goes away when once you start giving a cochlear implant, and tinnitus will not become a bothersome for them. But in case if it's still a bothersome for them, I told you there are some patients, at least 40% of patients will have other difficulties even if you give a hearing aid or cochlear implant. Okay, so that is there is no 100% confirmation that just by giving a hearing aid tinnitus goes away. No, doesn't go away. But most of them do not perceive the tinnitus when they are wearing a hearing aid. This is for sure. Okay, the same applies for cochlear implant. Now we move on to the tinnitus sound therapy. This is basically the masking. So before you doing masking, you have to do the minimum masking level that is required to mask the tinnitus. That is basically you get this level from the tinnitus loudness matching. Okay, once you have the tinnitus loudness matching, you present the that frequency sound, a narrowband noise at 10 dB above the tinnitus level, and present it for a few seconds and see if the tinnitus persists even when you stop the noise. If the tinnitus is reduced or tinnitus is absent completely after reducing the noise, then we call as a successful residual inhibition. Okay, the residual inhibition is present in most of them. Around 60% of them have a residual inhibition present. So they are very good candidate for tinnitus masking. Okay, so they are good candidates for hearing aids and they are good candidates for tinnitus masking. Okay, now if there is no residual inhibition for a patient, they are not a good patient for tinnitus masking. So lower residual inhibition with a normal audiogram suggests that important for different therapeutic intervention targeting with audiometric and non-audiometric systems. If there is a strong residual inhibition, indicates a stronger susceptibility in tinnitus modulation and could benefit more from intervention. So this intervention includes, you can give a hearing aid or you can go for a sound therapy. If there is a strong residual inhibition, they are very good candidate for tinnitus masking or sound therapy, or you can call hearing aid masker, whatever, which of all of this will definitely benefit these patients. And I have seen it does benefit the patients who have a residual inhibition, and for the patients who does not have a residual inhibition, it does not help. Rather, it becomes a negative impact on their quality of life. If you are recommended rehabilitation sound therapy for those who doesn't have a residual inhibition, if you give a sound therapy, then it can actually backfire. Basically, it can affect in negative ways. So I recommend not to go for that. Okay, so sound therapy can be a wearable device or non-wearable device, basically any environmental noise, fan noise, radio noise, TV noise, any of that can be advantageous. Sound therapy refers to use of sound to reveal the bothersome tinnitus. It is inclusive of several strategies. You can go for wearable device, external sounds, any of them. So wearable devices, you have some apps in the phones, they can use it, or there are tinnitus maskers specifically available from a company. They can use them, or we can also recommend them to listen to the fan noise or any of the noise by the radio or any of them. Okay. There's no hard and fast rule. You can go with any of them. Now I'll provide an evidence for this. There are some studies where they controlled in a controlled trial studies where they compared between patients with sound therapy and patients with TRT, that is tinnitus retraining therapy, and the sound therapy shows significant results in the first 3 months, which basically means that whatever the negative effects the patient had previously, with a sound therapy, that will go away. Okay, but TRT takes a time which is around 18 months. It will show a good results. Now coming on to the cognitive behavioral therapy. Okay, so cognitive behavioral therapy, please be educated. Cognitive behavioral therapy is not only for tinnitus, it's actually a general rehabilitation approach used for depression, anxiety problems in psychology. Okay, so the same is actually been brought to the tinnitus. Now, please understand, it is a problem, it is a technique adopted to remove the negative thoughts, depression, anxiety, not for a tinnitus. Please do understand. So cognitive therapy is a specific therapy that focuses on modifying problem emotions, thoughts and behaviors, and CBT can be applicable to patients with a tinnitus to help reduce negative responses and improve the quality of life. Please do understand, it will not alleviate the tinnitus or remove the tinnitus, it only removes the negative thoughts. CBT may be used in combination with other tinnitus management strategies, and it is also been included by all the recommendations. So CBT, all guidelines strongly recommend using a CBT because tinnitus negative reactions are the ones which is affecting a person. So if you remove the negative reactions, I think they'll come out of the tinnitus is what they presume. Okay, but we see the reality later. So CBT aims to identify, modify negative thoughts and behaviors by recognizing the interconnection, thoughts and emotions and actions. The studies indicate CBT only reduces annoyance related problems and improves health related quality of life and does not reduce tinnitus. Now, one of the biggest problem with the CBT is CBT actually came to tinnitus very recently. So they only track for 1 year and sometime, but not for a longer time. So they really don't know the negative thoughts that disappeared because of tinnitus, remember, tinnitus does not get reduced. Okay, tinnitus will be there. Now, okay, so you don't have can they mute? Okay. Now remember, CBT does not reduce tinnitus. Now, I am a patient with a tinnitus. I undergone a CBT for say 6 months, and my negative thoughts and depression, anxiety all gone away. But my tinnitus is still there. Now, I can still get the negative thoughts back once again after some time. So there is no sure of that. So that was the basic question. Most of the researchers and clinics abroad has this question. They really don't know the long-term effects of CBT. Does the CBT is a long-term or not? They don't know, and they don't have any information on that. Next is tinnitus retraining therapy. It was proposed by Jestedorf based on the tinnitus retraining therapy, which is the whole thought of tinnitus retraining therapy, or the basic idea is that you have a limbic system which is basically making these negative thoughts more enhanced, and because of that the tinnitus is becoming a bigger problem. So you counsel the patient on a regular basis and also give a sound therapy. Okay, so tinnitus retraining therapy is basically two things. One is you have a direct counseling almost on everyday basis or every week basis, and then you give a sound therapy to the patient. And the sound therapy also you give a step by step for them, and counseling also you give a step by step. It's a long process of counseling. I can give examples of a long process of counseling. That's actually very good for the psychologist. I don't know, are we really trying to counsel the patients like that? Okay. At least I am not trained like that. Okay. So the TRT protocol involves a structured case history and assessment, and then you have a directive counseling and then giving a sound treatment. Most of them, they say that, it really helps TRT. At least the initial studies have clearly shown it helps. There is a large scale study done in a clinics. It's a data from the clinics. So these clinics, they had data from the TRT. Some patients have undergone complete TRT. Some have undergone partial TRT, which is only including a counseling, and some have undergone SOC, that is standard care. It is basically a counseling and audiological treatment, basically giving a hearing aid or cochlear implant. That's it. Okay. So this study has compared all the three, and there was no difference between any of these treatment approaches in how the tinnitus is affecting the person's life. They did not find any difference in any of them. TRT is basically takes a longer time than the other ones. So that's it. Other than that, they did not find any big differences. So that's about tinnitus, and there are some new techniques have been introduced in the years 2008-9, progressive tinnitus management. So you focus on patient learning to self-manage the tinnitus, and PTM uses a clinical service structure which moves progressively with the patient needs. Okay, our tinnitus active treatment intervention using individualized counseling, and 4 areas are considered: thoughts, emotions, hearing and communication, sleep and concentration. Okay, so most of them try to handle the psychology. Now, before I end my presentation, always remember, tinnitus becomes a problem if a person is not able to handle his thoughts. The tinnitus becomes a problem. Now, what is all these studies, your CBT, your TRT, what they saying is this, only this. Now, tinnitus, if I have a tinnitus, okay, Now, my negative thoughts on the tinnitus is making my tinnitus a problem for me. So they are all along saying is, you handle your negative thoughts, your tinnitus will go away. This is the summary of the presentation. Yes, I finished on time.
Yes, sir.
Yeah.
Sir, can we take up some questions now?
Yes. 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 I'll stop. I'll stop sharing the screen.
Sure, sir.
Yeah. So I have seen some questions, but I have not read it them.
I'll read it, sir. I'll read it, sir.
Yeah. Yeah. Please.
Yes. How tinnitus is related? So from the start.
No, the first 4 questions I think I have answered them in the presentation.
Yes, sir. Yes, sir. Cochlear implants also have answered. Difference between TRT have answered. CBT have answered. Will yoga and pranayam relief help from tinnitus?
Yes.
Will yoga,
Yeah. Yoga and pranayama will definitely reduce tinnitus because they are more concentrating on reducing your thoughts. So, which will in turn slowly reduce your negative thoughts. And will, if you go into the complete theory of CBT, actually CBT is actually taken from okay, CBT is actually taken from Buddhist system. Okay. The Buddhists have this mindfulness activities. Basically, keep your mind calm. Don't let your mind fed by more thoughts. That is called mindfulness. So it's actually taken from Buddhism. Buddhism has taken from the Indian system. So it's actually yoga and pranayama, which is Buddhists have turned into mindfulness. So that's what is being used as CBT. Yes.
How to assure and counsel regarding the treatment efficacy? Suppose if I'm counseling regarding a treatment that it has 70% efficacy, how to motivate the patient to take up the treatment despite the low efficacy? Last time in OPD, a patient told me, you yourself are not confident in your treatment. So how to assure without giving guarantee?
Okay. So usually whatever people do in the globe, across the globe is this, they administer some questionnaire. So the questionnaire is actually filled by the patient himself and you score it and show it to the score for him. Okay. Once you get the score, you keep that as the first file, you give it treatment. The treatment usually you need to give at least for a month or two, or not less than that. No treatment will be helpful within a month or two. Okay, so they have to come regularly. Now, if you administer this on a regular basis and compare between the previous questionnaire responses and now the new questionnaire responses, if you find a difference, it is helping. And most of them, what they do is only that. And always remember, tell the patient tinnitus will not completely go away if they have a hearing loss. It's a physiological issue and they have to understand it.
The next question, sir, what is the management for somatosensory tinnitus?
Somatosensory tinnitus, most of the tinnitus is somatosensory. There is no specific management for somatosensory tinnitus. It is, you can go for CBT or TRT or you can go for sound therapy.
So if it is vascular, sir?
If it is vascular, it has to be medically treated.
Medically treated.
Yes.
So does the duration of stimuli presented for residual inhibition have an effect on RI?
Huh? Come again?
Does the duration of stimuli presented for residual inhibition, which will have an effect on residual inhibition?
Yes, it does have an effect. You should at least present for a minute.
What is conventional music therapy, sir?
So, conventional music therapy is any music which you like, you can listen to them. It's actually called conventional music therapy. Later, people took that and they tried modifying the music so that tinnitus reduces more. But all along, what I have seen is all of them works the same. There is no, it's yeah, it's all the same.
So can it be a calming music or
Yeah, yeah.
a water
Whichever music,
kind
yeah,
nature?
whichever the music you like, you can listen to that. There's no problem. If you like just noise, also you can listen to it. No problem.
So which questionnaire can you please share the name? Is it Tinnitus Handicap Index?
Tinnitus handicapped inventory is most commonly used across the globe. You can use that if it is available to you. I don't know if it is available in Telugu or any other languages.
Sir, is there any role of high frequency audiometry? How can be it helpful in our clinical practice?
Is this question related to tinnitus or is just about high frequency? So if you clarify,
It's just about high frequency audiometer, sir.
okay, if it is just about high frequency audiometer, see, high frequencies are important, okay,
Yes,
for
sir.
us. At least for Telugu and South Indian languages, high frequencies are important, at least till 10K. I don't know how many of you have done any speech acoustic analysis. So your sa, sha, we have three type of sa. Sa, sha, sa. Okay, these three sounds are in the frequency range of 6 to 10K. Sa is around 9. The peak is around 9. Sha is around 4 to 6. It's like that for Telugu at least. Telugu and Kannada and Tamil, Malayalam. Okay. Now,
So that question is related to the tinnitus. As high frequency audiometer nowadays, we were hearing more. So they were
yes,
asking the question regarding this. And also, I think most of the high audiometers, high frequency audiometers will have 12 kilohertz, and few are
yes,
like 18. Nowadays, everyone will facing so much of problem in higher
yes.
frequencies, sir.
Yeah, high frequencies are important, but there are so many clinical difficulties that we have to administer them. And you should understand those clinical difficulties before you jump on to high frequencies. It is because the noise that we have in the clinics and the high frequencies, your auditory system is not that sensitive to listen to them. So you have to present at very high intensity and you need to know the norms, and we don't have norms for Indian population, at least
So,
for our
sir,
clinic.
so for sir, for tinnitus, is it okay to have up to 10 kilohertz? I mean
Yes,
frequency.
yes, yes, yes.
Yes.
And
Okay. The
tinnitus
question.
does not go beyond 10K for most of them because we have taken around 100 patients. We've taken the audiograms and looked at the tinnitus where it falls. Usually, where the audiogram bends, where the bend comes in the audiogram, it's just within 1 octave to the bend. The tinnitus comes either higher or lower, usually.
So, who are better treatment respondents in tinnitus, males or females?
It is same.
To see.
Because
Kindly explain. Yes, sir. Kindly explain about sound therapy for tinnitus.
sound therapy is like this. See, there are different types of sound therapy. Some people recommend a narrowband noise. Some people recommend a broadband noise. Some people recommend a music. The music can be anything, any calming music or any type of music. So the sound therapy goes like this. Usually, what is recommended is you should present a sound level 10 dB above the tinnitus loudness and present it for a minute and ask them to stop and ask them was the tinnitus still there. So ask them to repeat this almost on everyday basis. Listen to that for a longer time, like at least 1 minute, 1 minute, 4 times or 6 times in a day. They can listen to it. So that's up to the client. See here, always remember, client is not always free. Okay. So he has only tinnitus is his problem. No, he has many other problems. Along with the tinnitus, it's also another problem for him. Okay. So he's not always free. So whenever he has a time, he can listen to it. And at least and 1 hour in a day, if he listens to for at least 3 months, they say there is a definite reduction in the tinnitus. That is, there's improvement in the tinnitus perception.
Sir, is this available in Telugu? And someone is asking to send if it is available in Telugu. Rajendra sir is asking about this.
I'm not sure if it is available.
No. Sorry to interrupt. It is available in Telugu. Those who want, they can send a mail to me.
Okay. Sorry, sir.
We have done a standardized one in thesis, so it is available. Actually, no, many of them not aware of this. So Telugu people, they can use for their Telugu clients.
Okay, sir. So can we cure tinnitus completely? From Aman Kumar Pal.
No. See, tinnitus by itself doesn't go away. Okay. I'll give a simple example. Tinnitus is a symptom. Tinnitus is not a disorder. Hearing loss is a symptom. Tinnitus is a symptom. Okay. They occur because of some physiological changes that happens in the human body. Okay. So the symptoms don't go away until or unless you treat the physiological condition in the body. Now, most of the physiological conditions related to the cochlea are not treatable. Maybe there are some gene therapies are coming up. I'm not sure if they treat acquired hearing loss, but they are treating genetic hearing loss, I'm sure, but they're not treating the acquired hearing loss yet.
Sir, any apps for managing tinnitus? Can you please recommend if there are any?
Yeah,
apps?
all the hearing aid companies, they have apps. So you can just Google them and you find Tinnitus Masker by Widex, Tinnitus Masker by Phonak. I think Phonak had a better tinnitus masker, which I tried last time.
So one more question, like which ear to give sound? I mean, for the tinnitus matching or affected ear or better ear?
Okay, so the tinnitus can be unilateral, bilateral. If the tinnitus is unilateral, be careful, confirm that it doesn't have any other medical conditions. And then you can, when you're giving a tinnitus, that is sound therapy or tinnitus masker, give it to the ear which has a tinnitus. Now, if you are testing the patient to know what is the frequency of tinnitus, loudness of tinnitus, you can use other ear for matching if other ear is normal only. If the other ear is not normal, then you can't use the other ear. Then you have to ask the patient to make sure that tinnitus, he doesn't perceive the tinnitus, but he perceives the external sound that you present. So what you can do is, here you can do two things. You can give a pulsating tone. If the tinnitus is continuous, give a pulsating tone. If the tinnitus is pulsating, give a continuous tone.
Okay.
So one of this you have to handle, basically find out.
So in which kind of medical conditions we need to avoid this, sir?
If the patient has, the tinnitus is because of vascular problems, the tinnitus is unilateral, having only unilateral condition with a vertigo, please send for medical confirmation. Or the patient has other medical conditions, tinnitus comes without any hearing loss, and the patient has says that he has sleep disturbances, headache. So these kind of things, please always remember, first get your medical reports complete, and then only you can go for a treatment.
So is there any difference between contralateral and ipsilateral matching?
There is, see, contralateral matching is only to make sure that he is able to match it clearly. Because ipsilateral matching is difficult most often. So that is why contralateral matching, there is no difference. You can use contralateral matching, no problem. But always remember, other ear is normal.
So it is always better for the contralateral.
Yes.
Yes. Okay, sir.
If other is normal. I don't know how many
Okay.
patients. So,
Okay, sir. Is there any standardized test for quick screening of tinnitus?
standardized test for tinnitus, I did not get the question.
Any standardized test for quick screening of tinnitus? They have posted. I think. I think that question was not so clear. Sir, in bilateral tinnitus, how to tinnitus matching can be done?
Yeah, that's what I'm saying. If it is a bilateral tinnitus, ask the patient if it is continuous or pulsating. If it is continuous, use pulsating. If it is pulsating, use continuous so that they can differentiate between these two and then they can match it.
If there are any questions, kindly post it as immediately as possible.
Sir, good evening, sir. Vijay Shankar here.
Yeah, tell me.
సార్ తెలుగులో అడగచ్చా సార్ ఒక క్వశ్చన్ సెన్స్ దిస్ సార్ ఇప్పుడు మీరు ఎంతసేపు చెప్పింది ఆడియాలజిస్ట్ కి టినైటిస్ పేషెంట్ మీ దగ్గరికి వస్తే ఏం చేయాలి ఏంటి ఏం చేయొచ్చు చేయకూడదు అని ఒక పేషెంట్ మీ ముందు ఉన్నప్పుడు ఒక టినైటిస్ పేషెంట్ వచ్చి మిమ్మల్ని ఒక క్వశ్చన్ అడిగాడు సార్ నాకు గుయ్య అనే శబ్దం వస్తుంది నేను ట్రీట్మెంట్ ఉందా లేదా డాక్టర్ గారు అని అడిగాడు సార్ పేషెంట్ మీరు ఏం చెప్తారు సార్ వుడ్ లైక్ టు హియర్ ఫ్రమ్ యూ 4-5 సెంటెన్సెస్ అట్లీస్ట్
ఓకే కెన్ ఐ సే ఇన్ తెలుగు
ప్లీజ్ సార్ ప్లీజ్
ఓకే పేషెంట్ అలా వచ్చినప్పుడు ఫస్ట్ కూర్చోబెట్టి నాయన ఎప్పటి నుంచి ఉంది ఏంటి ఆ వివరాలన్నీ అడిగిన తర్వాత అప్పుడు మనం పేషెంట్కి చెప్తామన్నమాట ఇప్పుడు ఈ టినైటిస్ నీకు ఏదైనా ఇబ్బంది పెడుతుందా నీ జీవితంలో నీకు నిద్ర సరిగ్గా పడుతుందా లేదా అన్నం సరిగ్గా సహిస్తుందా లేదా ఇంట్లో వాళ్ళతో మాట్లాడగలుగుతున్నావా ప్రశాంతంగా జాబ్ సరిగ్గా చేయగలుగుతున్నావా లేదా ఇవన్నీ అడగండి ఇవన్నీ ఎందుకు అడగాలి అంటే మీరు ఏ టినైటిస్ హ్యాండిక్యాప్డ్ ఇన్వెంటరీ తీసుకున్నా ఇవే ఉంటాయి దాంట్లో ఓకే సో ఇవే ఉన్నప్పుడు దాన్నే అడగండి ఇప్పుడు పేషెంట్ నాకు ఇవన్నీ ఇబ్బంది అవుతున్నాయి అట్లీస్ట్ 50%, 70%, 80% ఇబ్బంది అని అనుకున్నప్పుడు మాత్రమే చూడబ్బాయి నేను టినైటిస్ అయితే కంప్లీట్ గా పోదు కానీ నీ లైఫ్ లో ఏమైతే ఇబ్బందులు ఉన్నాయో వాటిని కొంతమటికి నేను తొలగించగలను ఈ టినైటిస్ ట్రైనింగ్ ద్వారా అని మాత్రం కన్ఫామ్ గా చెప్పొచ్చు మీరు అమ్మాయి క్లియర్ అర్థమైందా
మచ్ బెటర్
దాన్ని తగ్గించలేము కానీ దాని వల్ల వచ్చే మీకు లైఫ్ లో వచ్చే ప్రాబ్లమ్స్ ని మనం వర్కౌట్ చేసి తగ్గించాం
ఎస్
So the same thing they have asked to explain in English, sir.
Okay. Okay, if the patient comes to you with a tinnitus and says that I have this sound in the ear and the sound will go away, will the sound go away? Okay. So when the patient comes like that, see, usually patient is not aware. The patient presumes it's like any other medical condition and it just goes away with the medicine. Okay. So please tell him that it comes because of physiological reasons and doesn't go away. And then you can counsel him that you ask all the case history details and if you have any questionnaire available to you, administer. If you don't have a questionnaire available, please ask these questions. Are you able to sleep well? Are you able to have your food comfortably? Able to talk to your family members comfortably? And able to do your job or duty comfortably. So ask these questions. If they have difficulties in them, ask them to rate whether it is 50%, 70%, like that. Okay. Once they give you the rating, if you know that the rating is high enough, that is, if it is 50% and 70%, then they are at the moderate and moderately severe level of tinnitus. So then you can definitely tell them that, see, I can't reduce your tinnitus completely, but I can remove your negative thought that comes because of tinnitus can be clearly reduced and improves your life. So that you can say clearly.
సార్ ఇంకో క్వశ్చన్ సార్. సార్ ఇప్పుడు ఇదంతా మోస్ట్లీ కౌన్సిలింగ్ బేస్డ్.
అవును.
ఈ రిమూవల్ ఆఫ్ ఎఫెక్ట్స్ ఇవన్నీ మనకేమో మన కరికులంలో ఎక్కడ కూడా కౌన్సిలింగ్ ఎలా చేయాలి అనేది కూడా నేర్పిలా లేదు కూడా మన కరికులం. ఆర్ వి ద రైట్ పీపుల్ టు డీల్ విత్ దెమ్ ఆర్ సైకాలజిస్ట్?
Actually, we are not the right people to deal with them. But the problem is, see, the psychologists don't take up this. Okay.
Yes, sir.
If the psychologists are happy to take up, I think they are the better people. I don't know why people are promoting CBT more enough. I don't see it in any way, but I don't know. I don't see it. In my view, it's not my cup of tea.
Okay. Sir.
Sir,
Yeah.
Even in misophonia, they give this CBT.
Yes. CBT is a
that-
general technique. Okay.
Yes.
I see there is a general thought which I learnt myself. Okay. So not from any books. If you know to control your thought, this is what I say. If you know to control your thoughts, you don't have to go for a psychologist. You don't need a psychologist. Basically, a psychologist controls your thoughts. Basically, you are asking him to control your thoughts. I think I will control my thoughts myself. If you know that, to do it, and if the patient can listen to you and follow your steps, I think you can control. It's not a problem. But counseling is a long drawn process. Please do understand, it is not a simple one sentence. Let's say that somebody has a hearing loss and okay, you have a hearing loss, you take a hearing aid. It doesn't go like that. Okay, it's a long drawn process of counseling. I can give an example of counseling. If it's not important now, but if you want, I can give an example. Which I learned from.
Sorry for the interruption, sir. I'm about to ask you that. Can you give one small example, like how to control like our own thoughts, like how we can explain him better for the patient?
Okay, I see that is difficult for explain to the patient. Okay, they won't understand. But I can tell you how to control your thoughts.
Okay.
Let's say you have too many thoughts. Just stop breathing for that 1 second when you have too many thoughts, and just observe what happens when you just stop breathing. All your thoughts will go away. Okay, and you start breathing once again, when all thoughts comes back. You can observe yourself.
Yes, sir. When I stop breathing, it becomes more the major problem.
No, if you stop
nullified.
No. If you stop breathing, all thoughts will go away. When you start once again, all the thoughts will come back. So it is like this. Thoughts are like a cycle. So always try to break the cycle. You can do it in many ways. You can be in company of somebody or listen to something in the TV, or just pay attention to what you are listening. Do not listen to the content what they say. Just pay attention to what they are just saying. Sound. Your whole mind should be on the sound. Okay, not on the content. The problem is here. If you pay attention to the content, then all your thoughts will come back.
Okay.
Okay. If you pay attention to only the sound, your thoughts won't come back.
Okay, sir.
I think I do this. I just play any sound in my room, and I keep doing my job. So the sound is not a distractor to me. It's actually reminds me that whenever there is a thought, I should pay attention to the sound, not to the thought. So I just avoid the thought.
Okay, sir. Sir, one more doubt, sir.
Yes.
In condition of bilateral tinnitus, so you were saying like if it is continuous tinnitus, we have to give pulsatile tones, pulse tones, sir.
Yes.
Actually, we are matching, right? When it is continuous masking, sorry, tinnitus is there. Like how patient will match the pulse tone what we are giving to that? It should be similar, right?
Yeah, I know it is similar. The problem is this. if my tinnitus is pulsatile, if you give me a pulsatile tone, how do I match? Because I don't know what is tinnitus, what is the sound. I'm not able to differentiate them. So for the patient to have the comfort of differentiation, I suggested to use a difference, one which is convenient for the patient. That is why.
Okay. Okay. So first, which one to match, intensity or frequency? Which one would be easier? Like,
usually, I will go with the intensity first, and then I will go with the pitch, because intensity matching is always easy for most of the humans. Pitch matching is very easy for us.
Okay. Okay, sir. Thank you, sir.
Sir, I think we are done with the questions.
Okay. Thank you.
So from Rajendra sir, Dr. Rajendra sir have special thanks given to Dr. Narne sir.
Okay.
Yes. So yeah, we'll conclude this, and thank you so much for delivering such an insightful talk on tinnitus management, sir. Your expertise really broadened our understanding in condition and inspired to move and give so much of management to the patients to improve the quality of life. So without any delay, we are already running late. So I would like to invite our Honorable General Secretary, Mr.Gopi Venkatesh, sir.
I'll just say 2 words. Okay.
Yes, sir.
I am not funded by any of this TRT or CBT, so I never say positive or negative about all of them. Okay. So I have no financial interest nor any negative thoughts about them. Okay, whatever I said in the presentation is my clinical observations and what I've read in the publications. Done. Thank you.
Yes, sir. So now I would like to invite our Honorable General Secretary, Mr. Gopi Venkatesh of APSLPA, to deliver his vote of thanks before we conclude this webinar.
Okay. Thank you.
Good evening, sir.
Good evening, Gopi.
Thank you very much, sir, for your valuable insights on tinnitus management. Your presentation has greatly contributed to our understanding, making it easily to apply in our daily practice. Okay. On behalf of Apaslpa-Isha, we would like to extend our sincere appreciation for your time and effort by presenting you with a certificate of appreciation. Thank you once again, sir.
Thank you. Thank you, Gopi.
I thank all the participants. Once again, have a World Audiologist Day. Happy World Audiologist Day. Thank you very much.
Thank you. Thank you.
It's not too late now to hear clearly. Yeah, I know it's a lot to take